Welcome to the Point of Medicine podcast, brought to you by LearnNeuralTherapy.com. Doctors Ann Hill and Alana Gurvich team up to take a deep dive into the art and science of healing. This podcast explores cutting-edge approaches to the autonomic nervous system and its role in organizing fascia for optimal health. Each episode features conversations with leading clinicians who are pushing the boundaries of medicine, uncovering new insights, and transforming patient care. Join us as we bridge tradition and innovation to expand what's possible in modern healing. Just a reminder, this podcast is for educational and entertainment purposes only and not intended as medical advice. Please consult your healthcare provider before making any changes to your healthcare plan. Join us and let's jump into the next episode.
Hi, everybody. We are back with the Point of Medicine podcast, and we are really excited to have Dr. Kaczewer to join us today. Jorge, you have been at so many of the American conferences. I almost feel like you're an American neurotherapist. It's so great to have you there. And it's been really great fun getting to know you. You are, like, I think probably my favorite personality in the neurotherapy world.
Okay.
So I'm going to go ahead and introduce you, and I'm going to go through your bio. So hang on one second here, and then let me just get to that. Okay, so Dr. Kaczewer is a medical doctor graduating from the University of Buenos Aires. He has spent 45 years exploring health models with different technological or industrial medicine, so neurotherapy, neurofocal dentistry, anthroposophic medicine, that's great, homeopathy, homotoxicology, spinal manipulation, naturopathy. He was trained in neurotherapy in Colombia in 1997 by Dr. Pan, while practicing as a rural doctor in the San Marcos Sierras department of the Cruz. I hope I'm not messing this up. In the province of Córdoba. Okay, and he's certified by the CIMA Colombia and the International Medical Association of Neurotherapy, according to Honecker of Germany from 2004. You are the head of the neurotherapy unit of the Department of Complementary and Integrative Medicine of the facility of Maimonides University.
Maimonides University, yeah.
Where you conducted the first university course of neurotherapy held in Argentina. You're the founder and the director of the Argentine Institute of Neurotherapy. And this is a new thing for you, I think. So this is exciting to talk about this. And you've dedicated 19 years to promote research, development, and expansion of neurotherapy in Argentina and other countries in the Southern Cone. And since 2005 to date, you have taught 35 editions of neurotherapy and neurofocal dentistry courses. You've been a speaker on neurotherapy and neurofocal dentistry in several congresses, conferences, and diploma courses. And you're headmaster of the postgraduate academic course in neurotherapeutic medicine at the Faculty of Medicine of the National University of Rosario, Province of Santa Fe, Argentina.
Yeah, that's our most recent getting into the university,
Yeah.
But officially,
Yeah. So this is, can you tell, I hope you don't mind if I'm going to do the first question here. So you had to go to Colombia to study because there was not at the time anywhere in Argentina to study. Is that correct?
Yeah, I was a rural doctor in a 3,000 people little town in the Sierras of Córdoba province. I practiced already an eclectic cocktail of different alternative medicines, anthroposophy, vertebral therapy, vertebral manipulation, ecological nutrition, transpersonal or gestalt psychotherapy. And my patients really got really good from the consultations, but 15 or 10% of the patients didn't experience a single change. I couldn't get into the thing to get them better. So I said something is missing. So when I heard about neurotherapy, I realized it was that, the nervous system. So I heard about neurotherapy in a conference in 1996 of Arturo Birne. He was one of the neurotherapist that was trained in the first experience when in Colombia together with Payan. So I said he came to teach about homotoxicology, but he talked all the time about neurotherapy. So I said, this is what I need. Who gives the best courses, in America? So everybody tells me Payan. And so I called him during a year. And last he said, oh, come on, don't call me anymore. Just come. And so I said, so doctor, tell me how much do I need to take, how much money I need to take as the fee of the course. You just bring for your hotel and your food. You know, he trained me during 3 months with such generosity I never experienced before. So I came back and started practicing. But I was in the middle of nowhere, no internet. So my growth as a neurotherapist was very limited and very poor. So I decided to make some money. In order to do that, I moved to Buenos Aires and I started traveling. And then I got certified by IGNH, International Neurotherapy Federation, with from Germany. And there you go. I'm here. Yeah, there was nothing. Besides that, there was no one to learn from, just 2 or 3 more disciples of Payans in Argentina, but they were very, they were not as open as he. Okay.
Alana, you were going to ask.
How did you tell us why you even started? And, even before you discovered neurotherapy, you were practicing a very eclectic medicine. How did you even get into medicine, and why did you get into a more holistic or alternative, as opposed to conventional?
I always say I wanted to be a guitar player, an artist, a musician. I had showed more abilities as an architect than as a physician. But my mother died when I was 16 from 2 cancers, not only one. So it was logical, it was, a logical consequence for me to try to heal everyone from that. Since the very straight moment I got into medical school, I was already practicing yoga, meditation, natural food, natural nutrition. So, and I was working as an alternative journalist in the first magazines in Argentina, independent journalism, alternative journalism, that started to talk about alternative medicine, ecology, and all that. So I came into anthroposophy, for example, because I went to do an interview to the leader of anthroposophical community. And when I finished the interview, I showed it to him and I broke it and I said, I want to work with you. So I stayed with him 2 years as a personal assistant, and also an advertising assistant. And so I was part of the first course of anthroposophical medicine at 20 years old. At 21, I've been a disciple of a Japanese monk in Chinese medicine and Zen meditation. So I spent the same time I gave to my career, academic career, I gave it to my alternative experiences. So when I finished medical school, I didn't do a residence. I didn't do a specialization. I just went 1 year to a hospital, to learn the basics of things. And then I went to the field, to the country, as a rural doctor.
What was it like being a rural doctor? What kind of things were you seeing or treating? I'm just curious.
Yeah. Well, I must tell you, I thought that to live in a natural place would be very different from living in a big city. The pathologies are the same because the emotional problems are the same. Yeah, maybe a little less contamination, a little less toxicity, but the pathologies are the same. But I had a very nice experience. I organized a 24 hours, 7 days a week service of medicine, going to your place, medicine, emergency, not urgency medicine, not emergency. And I had a walkie-talkie. I had a how do you call handy, and I called the ambulance from a 20 kilometer town away, 20 kilometers away town. And so I got to have 400 affiliates, 400 associates, and I charged $5 a month each. So a family for $25 had a city doctor going to their house 24 hours a day without limit.
Mm-hmm.
But so I taught the mothers to give homeopathic remedies to their children at the first sight of a flu, of tonsillitis. And so if it didn't get well, they called me. So I've been being the whole day, for free in my chakra, in my working with the trees and with my orchard and with my vegetable garden and charging for that, So it was very nice. But the pathologies were the same, the same. Yeah.
So let's just dig into that a second. So you feel like pathology and the emotional state, that's the core of most of the pathologies you see till this
Yeah,
day?
yeah. I think stress, I think emotional states are 100% conditioning what happens. Yeah, yeah.
More than the physical. Because, I think about pathology, with people in the rural area, it would be like chronic heart, cardiovascular issues, and chronic lung and stuff like that. But no, you think stress is the underlying cause and then it presents in the body.
Yeah, but emotional stress. Yeah, I had very few cases of agriculture toxics. Intoxication. I had very few cases of trauma. Very few, very few. The most of it was chronic ailments. Uh, chronic ailments or recurring ailments, like the children with tonsillitis or the children with flu or the adults with arthritis or the adults with, chronic degenerative illnesses. Yeah. Yeah. Quite the same.
Did you learn homotoxicology in medical school, or is that something you learned afterwards?
No,
You would,
homotoxicology. I was
can you explain what that is for our viewers? Because some people might
Yeah,
not.
very weird. Homotoxicology is a very special form of scientific homeopathy. It grows from the work of Heinrich Reckeweg. He was a pharmacologist, toxicologist, clinical clinician, and pathologist in the 20s in Germany. And his father got cured from a kidney cancer in the 20s, in the 30s. And so by the 40s, he was one of the best homeopathy teachers in Europe. And his dream was to fusion homeopathy and scientific medicine, and biomedicine. And so he came out with homotoxicology. That means that illnesses come from homotoxins, and homotoxins gather, in the body, and the body doing, confronting this toxicity is what we call illness. So it goes into some stages. At first, we take toxins out through the conventional channels, our secretions and everything. And when that is not enough, the organism calls for the help of bacteria. And so we start, bacteria help us to take the toxins out, through our four skins, the skin, the mucosal, the digestive mucosal, breathing mucosa, and urogenital mucosa. So these are our four skins in contact with the exterior environment. And so they conjugate toxins, and so the toxin goes out without damaging the mucosas. And the doctor thinks erroneously that bacteria are the enemy, the cause of the ailment. But inflammation just shows that this area is full of toxins. But he gives an antibiotic, So he is, shooting to the conductors of the cranes that help us put the containers on the ships in the port. So every mucosa starts reacting as a chronic syndrome of mucosal inflammation. So it's an inflammatory chronic syndrome. And so we have a medicine, a biomedicine that validates behavior, a medical behavior that promotes silent inflammation, chronic inflammation. So once you start uh, taking that into account, you start helping the patients to be less inflamed, and they cure themselves alone.
So today, how you practice now, before we started recording, you were telling me you see patients 5 days a week in your clinic, plus you teach. So now, how do you use homotoxicology or homeopathy or neural therapy?
No, no, I don't use it anymore.
What do
I
you do
don't use
now?
it. I
Paint us a
do
picture of how you
plain
practice now.
neurotherapy, only
Okay.
neurotherapy.
So
I
what does that look
abandoned
like?
everything. I abandoned everything because I came to realize, I abandoned everything. I came to realize that I liked much more the dynamics of neurotherapy than that of homeopathy or homotoxicology. I like a dynamics centered in ill people, in sick people, and not in sicknesses, in illnesses and diseases. So I just practice pure neurotherapy. I do a little vertebral therapy when I get to know my patient needs it. He has a impingement syndrome, a vertebral impingement syndrome. So I try to help him with this, and that's it. I was trained in orthomolecular medicine, but I don't use it anymore.
Okay.
When I need someone to get chelated or someone to get receive nutritional orthomolecular medicine, I give it to some other disciple. I got a little bit tired on molecularization, life's molecularization, and I tried to see a more general picture. And neurotherapy has helped me a lot with that, because it's not the toxics themselves that are the cause, but the nervous system's reaction to the toxic, that gives the disease its characteristical, its features. So I trying to learn more about the nervous system got me deep into neurotherapy. So I practice that, only that.
Can you give us a fun case history? Like, what's one of your favorite
Huh?
what's one of your favorite patient stories of using neural therapy? Are there too many?
Oh, I got a lot of them, but I can tell you one. For example, there's one captain, ship captain, of the army here, that was in the Argentinian ship that went to the Gulf War, to help American plane ships. How you call the one that transports the planes? Yeah, the big ship.
Yeah.
I went to help as an assistant of these ships. And so during these days, it was very traumatic, because they kept all the time rehearsing at night. They slept, with the clothes on, and they couldn't have a rest, a single moment of rest. And so when he came back from that, he started having violent fighting nightmares. Every night fighting during sleep, and fighting literally. He fractured his bones. He broke his bones 3 times. And so he was prescribed eight remedies, eight allopathic psychiatric remedies, and they discharged him, telling him this is for life. And so when he comes to consultation, I just put 2 drops in his tonsil surgery scar, and 1 or 2 milliliters in each side of the prostate plexus, because he had when he was very young 3 times gonorrhea. First consultation, he comes to the second, 50% of the nights, no nightmares. I repeat, second and third consultation, he comes, no more nightmares. His daughter and his son telling me, instead of having violent nightmares, he laughs during sleep. So this is a very good case. I made him record the testimony. I have a lot of cases like that. I have multiple sclerosis cases that in one consultation, they went back, to normal studies, not more showing the myelin sheets damage in one consultation, just doing a tonsil scar or some whatever interference field I detect. So every case is a favorite case in neurotherapy. Every case opens a whole world of investigation, of research subjects, And I could tell you hundreds of cases.
Do you have a favorite tool to use to find interference fields? Like, is it based on history when you feel something? Is
Yeah.
it muscle testing?
It's called dialogotron. We dialogue. We just dialogue. I don't use dynamic muscle tests or whatever, or measurement tests, because the best explanation for that, the best reason for not relying on these, I heard it from a very good writer, Mark Mikosi, and in his book A Story of Key, and I embraced it since then. It's that we are very fond of certainty, and so certainty as a doctor gives us a very strong tendency to pride, to the healer's pride, and this is very dangerous, because if you don't value uncertainty, you can awake very hidden, occult, strong forces in the patient, because inside every patient, there's a store of guilt for having destroyed this world so much. Even if the patient is not conscious, the guilt is there. And if you awaken that, the patient can have very strong reactions, even if you go on based on your certainty. So I love uncertainty. And so dialoguing is the best for me. And asking to the body is the best for me. So I ask the body how, just doing the injection technique on the places I believe from dialogue that the body is telling me, hey, you please make a punch there. So there's no magic on that, It's very easy. If the guy was raised in a city during the last 5, 6, 7 decades, he has got antibiotics as a child, so I go to the tonsil scars. Most patients have a tonsil scar interference field. And maybe sometimes you have to have it 3 times, 3 consultations for it to reveal its effects. The umbilical point also is very frequent because we have an obstetrical work very, very, very interferent, very toxic, very violent sometimes. I sometimes, concerning that interference field, I sometimes detect very, very clearly what Stanislav Grof has called the perinatal matrices, patterns. The pattern, if the damage came during the
Birth?
fetal development, or if it came during the transit, the going through the birth canal, and if the trauma came in the immediate after being born, or if it came afterwards during the feeding, the maternal feeding stage. And so it's very clear. For example, there's I think it was Dietmar that said, or maybe Scheidt, Walter Scheidt had a theory during the 40s and 50s that interference fields go as an onion, with its layers. So when you help the organism metabolizing, the most surface layer, so the other emerges. No? So I get this woman, 60-year-old woman, to consultation, and after the first consultation, she calls me and says she starts being violent to every man that gets near her. After the third consultation, we process some layers of interference fields, and I deduced from that maybe this was like going into a pre-rational trauma, like maybe something happened when she was inside the uterus. I don't know, who tells? But maybe. Yeah.
Cool. Yeah. Can you talk a little bit, Ilana, unless you have a question?
No,
I want to know more about the school program that you've started. Is it through? Tell us a little bit about.
Maybe before you do that, can you tell us what is the state of neural therapy in Argentina? Like, where does it fit in, and then how are you changing?
Neural therapy is a very strange case in Argentina because one of the schools of the international schools during the 40s that used local anesthetics as a therapy, not as a surgery ailment, aid, not as a surgery use, was in Argentina. From the Finocchieto brothers, and Alfonso Albanese, made a manual of it. The manual is called anesthetic blocks of the neurovegetative anesthetic blocks, manual of neurovegetative anesthetic blocks. And so this tells us there's a very, very, very old school of therapeutic and pain use of anesthetic blocks of ganglia and the neurovegetative system in Argentina. There were a lot. We had an epidemic, a polio epidemic, and one of the most famous in the world pediatricians, Dr. Florencio Scardó, used the anesthetic blocks of lumbar ganglia to prevent spasticity in children, from polio. And so it's very old here, but it wasn't called neurotherapy because the Huneke weren't accepted into academic publishing and into academic circuits, so nobody mentions them. But we have a lot of material on that. Yeah, there were a lot. For example, there's one neurotherapist, Julio Sayach, a contemporary one. He's part of a group in the postgraduate course, and his father made the first pain clinical center in a hospital in South America. And he was visited by Bonica, for example. John Bonica. So we have a very strong tradition here. But neurotherapy, a therapy practice, not a neurotherapy oriented to illnesses, to pain, but to every kind of ailments, because it's oriented to sick people, to diseased people, and not to patients, not to illnesses. So we have a tradition introduced by Julio César Payán. So this started during the 80s and so there was Ricardo Machiavelli, for example, one of the first disciples of Payán, and he had a service in the Eva Perón Hospital. in an official hospital. He was a very friend of the chief of surgery and anesthesia departments, both of them, and allowed him to have a service of neurotherapy in there. But it was called a service of neurotherapy and pain therapy, for example. My first course in Maimonides University in 2004, we had to call it academic course of neurotherapy and pain therapy, for example, because if not, they wouldn't accept it. You understand? So neurotherapy is still not accepted, not as such, inside the system, but there's a lot of people inside the system that are very fond of it. So if I go into a hospital, for example, if I go into a hospital and tell the chief of the urgency service, of the, how do you call it?
Urgent care, emergency medicine.
Emergency care. And I have a friend, for example, I have a patient there with a heart ailment, with heart attack, and I tell him I am his doctor. Can I practice a stellate ganglion block in the tradition of the Finocchietos and Albanese? And he would let me do it.
You can't say, can I do neural therapy on him?
No, I can't say that. I can't say it because they don't know it. They know Albanese and Finocchieto, but they don't know neurotherapy. Now they will know, because we are in a public university. And the news is that we will start, maybe this year, we will start giving neurotherapy as an elective subject, an elective subject for the pre-grade, for the boys studying medicine. During 5th and 6th year, they can take neurotherapy as an elective subject. So this will be like infecting the whole university.
So there is knowledge of the therapy. Physicians know about neurotherapy, but it's not mainstream, but it's moving in that direction a little bit.
Yeah, it will. It will be a specialization soon.
And then
it is kind of a specialization for regional anesthesia and local anesthesia for anesthesiologists and that. Pain specialization includes a lot of neurotherapy in every university here. Yeah. But they don't mention neurotherapy. They mention the blocks, the injection blocks,
And so now tell us about the course you're teaching through the medical school.
Okay, I give a 2-year, we started in June last year, a 2-year postgraduate course. The teachers' staff is really, really fantastic because it gathers the best neurotherapists from all over the world. David Viñez from Spain, even Michael Gurevich from New York, and Perry, and the Colombian guys, the Colombian neurotherapists also. They are very, very important, dentists. My teacher in neurofocal dentistry, Dr. Jose Osorio, and the other dentists and doctors that practice, that Payan trained with her, together with her. So this is a very, very, very important because of the group, so the participants are exposed to the best neurotherapy all over the world. So I hope sometimes I wanted to do it in English, with translation, with simultaneous translation. I couldn't because it was very expensive to translate it. So we couldn't. But we had 50 participants this year. We have 50 participants. And now Rosario University has validated my second group for this year that starts. I will do it from Buenos Aires in my office. And they validate it. So I am very happy with it. Yeah. And we will have practice we'll have also practices, of injection technique with fresh cadavers, because I already had a meeting with the anatomy department of the university, and we will start also investigation, researching, interdisciplinary researching with radiology, trying to get CT scans of the injections and all that to make an advancement in the techniques and all that. But it's a nice project. I am very happy.
Just out of curiosity, how important do you think it is to utilize visualization techniques when you're injecting? Like, how valuable do you think is it to do ultrasound-guided injections?
Well, I would love biomedicine could understand that there's a very, very huge story of practicing with the
Palpation.
CT scans in the point of the fingers. My thumb is the CT scanner because it's feeling all the time where the needle tip is advancing. So I practiced neurotherapy for 28 years, and I had very, very, very little incidents of accidents. I had 2 or 3 accidents doing a deep injection in 28 years, in tens of thousands of injections. I had not more than 5. Not more than 5. I believe it's 4. One was a lumbar ganglia injection when the guy that delivered me, the patient, didn't tell me she was into amphetamines, and she didn't tell me. So I did a lumbar injection at the right side, and she made a purulent, a pus gathering in the other side as a neurodystrophic reaction. And that was one. The other one was a guy I made celiac ganglion injection, and he was sitting in the consultation room, and so I made this, to fix some material, and he fell because he had a faintment. So I had to suture to make stitches in his head. That was the other one. And I had one episode during giving a prostate injection. The guy, made a sudden movement, and we had a collection, a blood collection, a blood hematome, retroperitoneal, and we didn't have to do surgery. That was all in 28 years. So if I'm the type of guy that see something done 2 or 3 times, and I do it. So this is my grandson. He lives with me. So we start in this training, university training. We start from the very first day. During the morning, we do theoretical classes, but during the afternoon, we start seeing patients. And so the participants first start to see, to watch, to make a clinical training, looking at it, at the process. Then, at the middle of the course, they start doing themselves the clinical, supervised by a trainer. At the end of the training, they will have to present a case that they managed alone.
And these are all practicing physicians. These are all postgraduate.
Postgraduate, yeah. Yeah, we accept dentists and doctors, and we have nurses also. We trained nurses from the very first time, and my official nurse guy, the one that makes the intravenous applications, the intravenous injections or intravenous serums of procaine serum, is a nurse trained by me. He made a complete training. And I believe nurse professionals have to be trained in neurotherapy. Maybe not to do as much as deep injections as we do, but to help us in all, the medical set, the consultation in neurotherapy, to help us and to take in their hands, the superficial injections or the intravenous ones, Yeah. So we have nurses, and we have 2 in this experience, academic experience. Yeah.
So do the nurses do like 2 years as well, or is there less time?
Yeah, they do the whole training as well.
Okay.
Yeah. I believe the most important thing in these trainings is the philosophical stance, the philosophical aspects of from where do you stand when you are confronted to a patient, and how do you feel and see the patient's process is very important. So the most you deepen into that, the most important is one of the ways that the consultation in neurotherapy affects people. It's not all the work done by the injection or by the interference field treatment or anything, but it's also by your point of view is very important. If you take quantum physics into account, and the fact that today there's a conception of atoms, including atoms as organisms, there's not more any philosophical view of inert physical matter and living beings. No, everything is alive. The universe is alive. If you take that into account, it's very important. Your philosophical clarification, your philosophical point of view, it's very important,
So I'm going to ask you an impossible question, but
Let me see.
I'm just
I like those.
So, 10,000 patients. Do you have a favorite injection? Do you have an injection that you feel is like more likely to cause a lightning reaction? Like, is there one that you find yourself pulling on again and again?
Yeah. Yeah, the celiac ganglion injection. It's very strong. It's very strong. It's one of the best injections that contribute to your healer's pride because the effects are incredible. They are fantastic. When you go deeply into celiac ganglion, pre-aortic plexus, and the lateral sympathetic chain, the reaction of the patient is very, 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 very incredible.
You are doing an anterior or a posterior insertion?
Posterior, yeah, like
From like L1, you're inserting L1?
between L1, L2, and sometimes between dorsal 12 and L1. When I want to affect more the superior abdominal organs, like stomach, pancreas, I try to reach the plexus from its inception from the splanchnic nerves, going inside from T12 to L in the middle of T12 and L1. Yeah.
How many mils is your...
You have to make the patient go deeply, exhalation, a deep exhalation, and hold his breath so as not to puncture, the diaphragm. I never had an accident with that, so I do it. Yeah.
How long of a needle are you using? How many mils?
12 centimeters.
12 centimeters.
Yeah, that's 6 inches, no, 5 inches and a half. Yeah.
Jorge, you did a talk, I think a couple years ago at this point, for the NAANT that I was bummed because I missed it, but I really appreciated you sharing your notes with me, kind of about the history of neural therapy. Are you gonna be doing any more talks that we would like to join?
Yeah, why not? I made a nervism seminar now with the guys of Acolten, of the Colombian. They translated my Russian nervism seminar that I gave in Bogota. They translated full into English, and so we now finished recently. But we will do another edition, and whenever you want, I'm there for giving any class you need.
What's nervism? I don't know what that translates to. Do you know?
The idea of spreading the nervous system action or influx into the most of the activities of the organism. That's nervism. Russian nervism is a Russian neurobiology and neurophysiology, and it's very different from Western or biomedical classic Western neurophysiology in the sense that it works, it makes its research with full animals and or full individuals, not with parts of the organism, and try to do it contextually. And so they had a very, very, very much decades before us, they had a sense of what now is emerging as everywhere, the notion of really the importance of nervous system function as a coordinator, not only of health, but also of pathology. So it's kind of the greatest part of neurotherapy foundation, scientific foundations, come from Speransky's work, from the notion of interference field. From the 40s on, the Huneke relied on the translation that von Roques made of the book of Speransky's book, a basis for a theory of a new theory of medicine, where he shows like 30 years of research with animals, with dogs, on the interference field concept. With the first stroke and the second stroke comes from there. So our patients come with a lot of first strokes, not only one. For example, a typical patient that comes into our office with a chronic ailment has a tonsil scar or a tonsil interference field from taking a lot of antibiotics for tonsillitis or whatever, or sinusitis or otitis, whatever. And so also, if it's a woman, she has a great probability of having a gynecological interference field, uterovaginal plexus. And if it's the guy, prostate plexus also because of sexual infections, during adolescence, during its first experiences. And so they're very typical interference fields, For example, every patient that comes with a diabetes hypertension ailment has an intestinal interference field.
Which then you...
So I don't do the three of them in the same consultation, but I start dialoguing with the organism in that way. So I like to compare a neurotherapy session as a dialogue. I dialogue with the patient's organism, and he talks in symptoms, and I answer in injections. And so it's like every dialogue. You have to be, You have to hear the other one, and you don't have to interrupt the other one, or you don't have to be very slow to respond, to answer. So it's kind of the same as a dialogue. And we have very, very linguistic bodies, so the body answers if you ask.
Go ahead, Juan.
Okay, so they come in, and you're saying any diabetic, anybody with hypertension, any of
No,
this,
no, no, no. I don't say any, but I said there's a typical tendency.
and that tendency would be an intestinal interference field, which you would then correct with a celiac ganglion or some kind of more superficial.
No. We do. If you want to cover the whole digestive system, you have to do the celiac ganglion, the sacral foramens, 2 to 4, and superficial quadal therapy, like abdomen segment. Yeah. And you do these three things, and you're covering the whole intestinal. For example, I will tell you a case. I have a very, very, very fond. I'm very fond of a patient. He came to me first time with diabetes and hypertension, and he tells me they had taken from his colonoscopy 12 polyps, and so I start seeing him regularly, like every 2 months, 5 times a year. And so the second year they do a colonoscopy and they got 6 polyps. And the third year they got only 2. And the fourth, no more polyps. Just with doing this set of injections 2 or 3 or 4 times a year.
Do you have a moment to talk just really briefly about the first time I learned about Speransky's, the experiments that he was doing was in David Vinas's class. Do you think you could give a quick synopsis of what he did to help us understand the interference field?
Yeah, we have a wrong history telling in neurotherapy because everybody ascribes neurotherapy injections in Russia to the Vishnevskys. But the most famous diffusion, the most effective diffusion of these injections was made by Speransky. And the idea that neurotherapy injection, that Novocaine injection, gives a replacement of the strong impulses the organism is getting from where it draws irritation, by a mild irritation caused by the procaine is Speransky's idea, not Vishnevsky's idea. It's kind of a massage, you do to the organism. So Speransky was commended by Pavlov. Pavlov saw the trophic importance of the nervous system, and partially, and with his first work on cardiac nerves, when he examined, we still didn't even call the vagus at that time. And so he commended to his disciples, to explore the role of the autonomic nervous system in this trophic activity of the nervous system. And so Orbeli took on the sympathetic system as the player, and Speransky started exploring the trophic role of the nervous system in pathology. He was a pathologist, a neuropathologist. And for example, Bykov was commended to study the same thing, but in the relation of cortex and subcortex ganglia, cortical and subcortical influence of the nervous system in this trophic role. So Speransky started a very thorough experimentation with dogs. He designed an operation, a surgery that set an irritation, a chronic irritation, on the hypothalamus. He put a glass bead in the tubercinarium, and the animals survived because he was very good at doing it. And so he fastly, he turned out to be the right hand of Pavlov's. In Koltushi, the Bolsheviks built a whole city for Pavlov to do this research. And in Koltushi, the Pavlov's office was immediate to it was Speransky's office. So he was the right hand, because Speransky was proposed even by Pavlov to be a Nobel Prize 8 times. So it's not bullshit, his experimentation, his research. And he started seeing that there were 5 groups of dogs concerning their reaction. Some dogs immediately started, running in circles and died. The others did this after a week. There were other groups that during a year and a half started showing dystrophic changes like loss of hair, sore throat, caries, cavities, gum problems, and digestive problems like bleeding, intestinal bleeding, and all that. And there was a 5th group that didn't show anything. But this group, even at the slightest stimuli that usually any dog would tolerate very easily, after 1 year or 2, they suffered the same syndrome and died. So he concluded that the system stored a memory of this trauma, in this hypothalamic trauma. The system stored a memory, and that this memory could be reawakened by another stimuli, by the second stroke, So from there, we obtain our interference field foundation, It's just from Russian nervism. So this was forgotten very soon during the 60s in Germany. Speransky's book's translation was forbidden by the Nazis, So it only saw light in the 50s, during 1950. And during the 60s, it was soon forgotten. And it was reawakened by Payan, and by all the Colombian group, because there was a Colombian guy that studied with Dosch. After taking one patient and Dosch curing him, he became a disciple of Dosch. And so the Germans traveled a lot to Colombia during the 70s, and to Mexico also, but mainly to Colombia. So nervism was very much revitalized by the teachings of Payan. So that's nervism. There were some other researchers contemporary also to Pavlov and to Speransky, like Uchtomsky, Anokhin, and they were very, very pioneering. They have pioneering work on the fact that you don't need neurons to be in contact for them to function as a functional system. Neurons communicate by its frequency of discharge, and they have a complete different view to Western neurology or neuroscience, because Western neuroscience shows neurons as transmitters of impulses, carriers of impulses. And the Russians see neurons as achievers of results. And this is very different, because there's certainly an electrical potential, because neurons are very, very, very huge and prolonged, very, very long organisms. And so the secretory pole must know what's going on in the absorbent pole. So you need the potential. But this is not the main thing, you understand? So they have a very active view of neuron work, and we have a very reactive, For us, it's a reaction to an impulse. For them, it's the result of an action.
Oh, interesting.
It's very different. So we dig the past deeds, that affect the neuron, and they dig the future deeds that affect the neuron. So it's a complete different neurology.
Wow. Thanks for...
Yeah, I must say, as an extreme view, that we don't have a brain here. We have a very huge gathering of primitive beings we call neurons, but they are primitive beings that have self-referent cognition, and they dig to live. They fly away from pain like us, and they start activating at the onset of damage. So it's a very different view.
All right. Ilana, do you have any more questions?
We'd like to end the podcast with just what inspires you. What's the most inspiring thing that you can think of about where medicine is going with all the changes that we have now in technology and knowledge? What's the most inspiring thing for you about where medicine is going, especially in the context of with neural therapy?
I believe that you can't separate this from the planetary context. And the planetary context is that there's a global north working on the energy and work of the global south. And when someone at the global south raises his hand saying, I need this, they put him at a dictatorship or a credit card, to silence him. So I see medicine going to a more equitative, more equal distribution of access, So neurotherapy is very important, because if we can get a neurotherapist into every APS, APS means primary attention of health, like what was accorded in Alma-Ata, So into every APS you get a neurotherapist, things can change a lot, and really humanity can get to really affect the statistics, the illness statistics, for example, concerning chronic degenerative illnesses, and also the fact that biomedicine is somehow one of the main causes of death now. But what inspires me most is the very simple way that neurotherapy gets its results. So you don't need any money, you don't need any technological development. So it's very suitable for the South world, for the global South world. So this is very, very motivating for me.
Great. Wonderful.
Thank you, Jorge. We really appreciate your time and
Yeah.
your knowledge and your commitment to teaching what you know, which is, I think, making a difference for everybody who's studying with you.
Yeah. I like it because I am the one that learns the more.
I agree.
Yeah. It's very selfish. Okay. Thank you for the space.
Thank you so much.
Thank you.
Bye.
Okay.
Thanks so much.
Okay.
Bye-bye.
Thanks for joining us today. If you like the episode, please like and subscribe to our channel and review us on your podcast players. Also, if you think this episode is helpful to some of your friends or colleagues, please share it widely. If you are curious about learning about neural therapy or other injection techniques, check out our courses on learnneuraltherapy.com. We'll see you next month for our next installment of the Point of Medicine podcast.